So good afternoon to all of you. In the last class, we talked about acyanotic heart disease. So I thought to complete the chapter on congenital heart disease, we'll go on to cyanotic heart disease in this class. This is, of course, an important chapter for the examinations, though it's not a common disease that you encounter in real life. So probably this is the most exam-oriented class that I have taken in this series, but I'll try to make it more of understanding and less of facts, because facts you can always pick up. Understanding is what makes you remember facts more easily. So let's look at cyanotic congenital heart disease. So in this class, we'll try to cover these chapters: Tetralogy of Fallot, Ebstein's anomaly, transposition of great vessels, double outlet right ventricle, and total anomalous pulmonary venous connections, or total anomalous pulmonary venous drainage, as it's also called. All these are cyanotic congenital heart diseases. So if you see a cyanosis and a heart disease in an adult, one of these could be a differential diagnosis. So of which Tetralogy of Fallot is probably the most important and the most common. So we'll discuss a little more in detail about Tetralogy of Fallot and then go over the other things as way of completion. I'll also cover one small chapter in the end, which is coarctation of aorta, that is sometimes kept in the exam as a short case. So we should be able to recognize and discuss. That is not cyanotic, but I'm just adding it as the last. So moving on to Tetralogy of Fallot, like we said, it's the commonest cyanotic congenital heart disease at birth, and people with certain features of tetralogy do survive till adulthood, and that's why they come to you as a patient, as adults, and then it's important for us to make a diagnosis. So as we all know, there are 4 components of Tetralogy of Fallot. The first one is that there is an infundibular pulmonary stenosis, which is what you see here. There's a narrowing of the pulmonary artery here. There's an overriding aorta, which is what you see here again. That is the aorta. The aorta is actually overriding both the ventricles. It's sitting over the right and the left ventricle. That's why it's called an overriding aorta. There is a non-restrictive VST, which is large, which is what you see here. There's a right ventricle, left ventricle. There's a VST with almost a non-existent septum. And there is a right ventricular hypertrophy, secondary to the presence of this narrowing of the pulmonary artery. So these are the 4 components: the infundibular pulmonary stenosis, the overriding of the aorta, the large non-restrictive VST, and the right ventricular hypertrophy. This we all know right from undergraduate days. Now, few points to remember, few points to emphasize are that the aorta is overriding. It's not in the left ventricle, it is sitting over both ventricles. You can have a right aortic arch in some patients, about 25% of TOF. They can have what we call as a right aortic arch. Aorta, instead of going this side, will go that side. So that's called a right-sided aortic arch. The VST is non-restrictive. That means it is big. So the shunt is like, bidirectional shunt is sitting there on the VST. It is not at all a small VST. And the RVH, though we say RVH, the RVH is actually mild, because whatever is there is shared between 2 ventricles as if it is a single ventricle. Now, very important point to remember is, out of the 4 features that we said, the pulmonary stenosis is the most crucial component. The pulmonary stenosis is the most important component of Fallot, which decides a lot of things. Now, why do we say that? The pulmonary stenosis is usually infundibular, but can be valvular and infundibular. Both are possible. Infundibular is, not at the valve, it is below, whereas the valvular is valvular PS. The second important point is the pulmonary stenosis can be mild or completely gone, which is what you call as a pulmonary atresia. So the degree of pulmonary stenosis is a spectrum. So you can have mild PS in a Fallot, or you can have complete stenosis of the pulmonary artery, what we call as pulmonary atresia, is also possible. So it's a spectrum, and this will decide when the patient will come to you, what will be his symptoms. All are dependent upon the degree of pulmonary stenosis. The third important thing to remember is that the pulmonary stenosis has a fixed and a dynamic component. So not only there's a pulmonary stenosis which is fixed, that means you can't enlarge it or decrease it, but there is a dynamic component because there is an entity called infundibular spasm. The lower part of the right ventricle, of the pulmonary valve, the infundibulum of the right ventricle can go into spasm in a tetralogy of Fallot, and that is where the dynamic component comes in. So all these three facts about PS are very important to us. One is it can be infundibular or it can be valvular. It can be mild or it can be completely blocked, and it can be fixed or it can be dynamic. Now, very important concepts. This is a very, very important slide in the understanding of a Fallot. Now, why is this person with Fallot cyanosed? Okay. So for that, we have to understand where is the shunt in a Fallot? Where is the shunt? Most people think it is here where there's a VSD and there's this thing, but the shunt is actually from the RV to the aorta. Like we said, the aorta is overriding. There is definitely deoxygenated blood coming to the right ventricle. Okay, it is there in the left ventricle, but what decides the cyanosis is the shunt between the RV and the aorta. The RV to aorta, the deoxygenated blood coming from here, going into the systemic circulation. This is what is the shunt in a tetralogy of Fallot. Next question. What decides the cyanosis? Again, most of us think it is this. It is not this VSD which decides the cyanosis. The cyanosis is decided by the pulmonary blood flow, because ultimately, whatever blood goes in the pulmonary artery, now this gets oxygenated and comes back, and that is what is going to save the patient. So the patient is alive in a tetralogy of Fallot. The patient is able to walk around in a tetralogy of Fallot. That is because there is some amount of oxygenated blood in him. Now, what decides that oxygenation? It is the amount of blood entering the pulmonary artery. So that's why we said in the last slide also, the pulmonary stenosis is the most important component of Fallot, which decides presentation and which decides prognosis, right? So let's remember these two important components. One is, where is the shunt? The shunt is from the RV to the aorta. What decides cyanosis? Cyanosis is decided upon by the amount of pulmonary blood flow. So if you have a very bad pulmonary stenosis, that patient will Fallot will be completely cyanosed. If you have a mild pulmonary stenosis, the cyanosis will be very less. So that's what is important for us to remember. Now, in infants, of course, we are adult physicians, but when we take a history of a patient with a tetralogy of Fallot, we always ask about what is called cyanotic spells. Now, what are these cyanotic spells? That suddenly the child, during episodes of feeding or crying, goes into a bluishness and goes into breathlessness. That is called a cyanotic spell. Now, like we said the pulmonary stenosis has two components. One is the fixed component. The other one is the dynamic component. The dynamic component of the Fallot is what we call as infundibular spasm. So in children, suddenly, for some reason, the infundibulum of the right ventricle, that is the top part of the right ventricle, goes into a spasm. When it goes into a spasm, what happens? The amount of blood going into the pulmonary circulation comes down. At that point, the child becomes very cyanosed. These are called cyanotic spells, and usually mothers of patients with tetralogy of Fallot report to us that the child becomes suddenly very bluish, struggling for breath, crying, etc. And automatically, the child also goes into some kind of a knee chest posture, or the mother tends to fold the knees of the child and put the child over her shoulder. This is not something that the mother read a medicine textbook and came, but automatically the child and the mother both try to put the child in a knee chest position, which is the equivalent of squatting in adults. I'll explain to you why this happens. But when we take a history of a tetralogy of Fallot, we must ask for a history of cyanotic spells in childhood or in infancy. So the presentation in children is what we call as tetralogy of Fallot. Spells are there. It's called TET spells. Crying causes infundibular spasm, decreases the pulmonary blood flow, more cyanosis. And acidosis or infection worsens the cyanosis because they all trigger off infundibular spasm. So children who become sick when they have tetralogy of Fallot due to any other reason or something that causes acidosis in them and whatever, all these things can trigger an infundibular spasm and make an already low pulmonary flow even lower. So the amount of blood going to pulmonary circulation is already less. But when you add on an infundibular spasm, that is when they go into proper cyanosis. Okay. Now, how do you treat a cyanotic spell? Like we said, put in knee chest position, which both the mother and the child learn by themselves. Beta blockers can be given. Pediatricians do give beta blockers for infundibular spasm. Morphine is another drug that is given to calm the child and also to decrease the infundibular spasm. 100% oxygen is given and a bicarb is given for the acidosis. Of course, we don't treat this. This is done in pediatrics, but sometimes you are asked in the exam, how do you treat a cyanotic spell? Then this is how we treat. We give beta blockers, we give morphine, we put the patient child on oxygen and also infuse a soda bicarb. Now, clinical features in adults is what we are interested in. So there is a breathlessness on exertion in patients with tetralogy of Fallot, and very classical history that this breathlessness is relieved by squatting, isn't it? So we always ask for a history of squatting in a patient with tetralogy of Fallot. And of course, they have noticed that the patient and the mother or parents have noticed that the child or the adolescent has bluish discoloration of the tongue and nails also. Right. Now, this is how a person squats. Okay, tetralogy of Fallot patient, whenever they get breathless, they sit down like that. Now, how does squatting help? What is the mechanism by which squatting helps? Now, look at this patient. When he is sitting down, what is he doing? He is folding off his legs. So what happens to peripheral arterial resistance? Peripheral arterial resistance increases, right? Increases. Now you look at this diagram. This is how the heart in tetralogy of Fallot is. Now, this ventricle, which is almost like a single ventricle, has two choices. It can push blood either into the aorta or it can push blood into this pulmonary artery. Now, if you increase the aortic pressure, which is what you're doing when you squat, okay? So the aortic pressure goes up. Then what happens? Less blood goes into the aorta, automatically more blood goes into the pulmonary circulation. So by increasing the peripheral resistance, what happens is that you're encouraging less aortic flow and more pulmonary flow, and more pulmonary flow always means less cyanosis. Remember, the most important component of the TOF, tetralogy of Fallot, is the degree of pulmonary stenosis, right? So here, because you are squatting and the peripheral arterial resistance increases, less blood goes into the aorta, more blood goes in the pulmonary circulation, patient gets less cyanosed, less breathless. So increased peripheral resistance, more blood into the pulmonary circulation. Now look at the second thing that squatting does. It prevents venous return from the legs and from the abdomen. So less desaturated blood is actually reaching the heart, right? So when you fold the legs like that and squeeze the abdomen like that, you are preventing the venous return from going to the heart. Much less venous return comes to the heart from the legs. And probably the legs have more desaturated blood than from the abdomen. I'm sorry. And so these are the ways of explaining why a squatting helps. So your patient, even though he has not read any Harrison, he squats because he knows that when he squats, he's better off. And we are trying to explain why he squats. Like when patients are orthopneic, they sit up, right? They are not reading any medicine textbook for that. They automatically do it because the body knows that that's a better posture. Similarly, in a tetralogy of Fallot, the person squats because he's encouraging more pulmonary flow, less aortic flow, increasing the oxygenation in the lungs, and also preventing the amount of venous return which is desaturated from reaching the heart. So you ultimately get a proportion, higher proportion of oxygenated blood, which relieves the cyanosis and which relieves the hypoxia. So this is the mechanism by which squatting helps. Now, we think that only tetralogy of Fallot causes squatting. There are many other conditions which can present with squatting, like tricuspid atresia. DORV is double aortic right ventricle with PS, which is the closest differential of any Fallot is DORV with PS, which is what is mentioned here as a second diagnosis. Any combination of a large VST and RVOT obstruction will improve with squatting, and rarely in Eisenmenger VSD, squatting is noted. I remember I had a patient with Eisenmenger VSD who was very clear that whenever he had breathlessness, he would simply squat and he will be better. So, but that is not common. That is only in 10%. But just I put up this slide for us to understand that squatting is not something that is very specific to Fallot. It can occur in many other conditions. Now, general examination, as we see, there is cyanosis in the tongue, there is cyanosis in the lips, there is cyanosis in the fingers, there is clubbing. Okay, cyanosis and clubbing, as we know, are always features of any cyanotic congenital heart disease, and it's a single cyanosis. So the whole body is cyanosed. You're not seeing the cyanosis everywhere except where the capillaries are visible. So that's why you're seeing it in the tongue and the nails. So the mechanism of cyanosis is central, and that is how we get cyanosis in all areas in a tetralogy of Fallot. Now, what will you get on examining the heart? The size of the heart is small. The heart is not an enlarged heart. It's a small heart. It's in fact a quiet heart. Okay, so you don't get all kinds of pulsations everywhere in a tetralogy of Fallot. For example, we say, very pulsatile precardiums are seen in an ASD, aortic regurgitation, certain conditions where all over the chest you see pulsations. But tetralogy of Fallot is one condition where it's a quiet heart. You don't find anything wrong when you do an inspection or a palpation. Hardly any findings are there. If at all there may be a sound which is palpable, it may be the loud S2. Okay, but otherwise, though we say ventricular hypertrophy, it's not much. You don't get a good going parasternal heave just because you have a right ventricular hypertrophy. So it's a very unimpressive inspection and palpation that you get in a tetralogy of Fallot. Hardly any findings. Then nothing to talk home about when you do an inspection or a palpation in a tetralogy of Fallot. Now, the most important features come from your auscultation. So in auscultation, as we all know, the most characteristic feature of a tetralogy of Fallot, I'm sorry, that's a mistake there. It's a single S2. Really sorry about it. It's a single S2, not an S1 there. That is because it's the only sound you're hearing is the A2, right? It's only the A2 that is heard. The P2 is not heard. It's a pulmonary stenosis, right? So you got a P2 which is not heard, and it is the aorta is anterior. So all you're hearing is the A2, and so it's a single S2, not S1. I'm sorry for that error there, right? There is a murmur in the heart. Okay, there is a murmur in the heart. What is that murmur? It is the ejection systolic murmur from the pulmonary area. So the pulmonary or infundibular stenosis through which the blood goes, that gives rise to an ESM in the pulmonary area. Remember, there is no murmur across the VSD because there is no turbulence. It's like a single ventricle, right? Because the VSD is so big, there's hardly any turbulence. There's nothing going on between the right ventricle, left ventricle. There is just one continuous chamber. So there is no murmur across the VSD. Whatever murmur we get is the ejection systolic murmur from the pulmonary area, and you get a single S2, single second sound, and that is the aortic second sound. The pulmonary component of the second sound is not heard in a Fallot. That's what gives rise to the single S2, and that S2 is the A2, and that A2 is heard well because the aorta is more anteriorly placed. When you do the investigations, all you will find is some mild ventricular hypertrophy in this ECG from a tetralogy of Fallot. You're hardly finding any features at all. So if at all, you will get some mild right ventricular hypertrophy. Maybe here in V1, you're finding an RS ratio more than 1, but otherwise there's no major right axis deviation. There is no P-pulmonale, nothing is there, right? Okay, fine. And so all you will get is a right ventricular hypertrophy. Again, not very impressive. On an X-ray, what do we find? We get what is called a boot-shaped heart. You can, I'm sorry, this is a lifting up of the apex far away from the diaphragm, and so it gives rise to a boot shape. Okay, that's what Coren's Herbert, that is a boot-shaped heart. So that's what you get when you have a right ventricular hypertrophy. Okay, and you can see, like we said, a right aortic arch. In 25% of the patient with TOF, you get a right aortic arch, which is what is seen, and there is a pulmonary oligemia, right? You got a pulmonary stenosis. So obviously, there is no plethora. The lungs are not congested. The lungs are oligemic. So that's what you're seeing on this X-ray, the boot-shaped heart, the right this thing of the aortic arch, and the pulmonary oligemia. Right? What do you see on an echo? You're seeing the overriding of the aorta. So the aorta is sitting on top of the right and left ventricle, and that's what you're seeing in this echo. And of course, you'll be able to make out the PS, which can be infundibular and valvular. Both are possible. So you make out all the 4 components of your tetralogy of Fallot by doing an echo. Now let's look at this problem. A 25-year-old man with TOF presents with right hemiparesis. What are the possibilities? What is the mechanism? I want you all to just write down. I'll give you 30 seconds. Just write down your possibilities and I'll show you the answer. So it's a person with TOF presenting with a neurological deficit. What are your possibilities and what is the mechanism? Many times I have seen exam cases being kept where you have a TOF with a neurological deficit. That's how they keep an exam case, right? And the patient is cyanosed, you know, he's young, and then you know he's probably got a tetralogy of Fallot. So then you're asking yourself, why the hemiparesis? I hope you have written your answers. Let me project. Okay. Now, the first 3 things what I've shown you here, these are all in children. Cyanotic spells, developmental delay, and poor nutrition. From here starts why you get the right hemiparesis. Most patients with tetralogic Fallot have polycythemia. There is an erythrocytosis secondary to the hypoxia, and that leads to hyperviscosity. And so you can get a cortical vein thrombosis, you can get an arterial stroke, you can get a brain abscess because you can have infections coming in, and you can have a paradoxical embolism. So all these are reasons why a person with a tetralogy of Fallot will present with an hemiparesis. So there is a polycythemia, there is a hyperviscosity, which can lead to a venous thrombosis or an arterial thrombosis, or you can get a brain abscess because of infective endocarditis or even otherwise, and also you can get a paradoxical embolism starting from any of the chambers. Now, what is the differential diagnosis of a tetralogy of Fallot? One is what we call as an acyanotic Fallot, which is where the PS is mild. Okay, when the pulmonary stenosis is mild, then the person becomes less cyanotic. That is what you call as an acyanotic Fallot. And the second important this thing is Eisenmenger's, where a person has severe pulmonary hypertension as opposed to tetralogy of Fallot. Here also there is cyanosis. Sorry, there also there is cyanosis. But in Eisenmenger's, very characteristically, you will get the A wave in the neck, then you get a loud P2, then you get your parasternal heave, all the other and an ESM in the pulmonary area. All are features of severe pulmonary artery hypertension. Here in tetralogy of Fallot, there is no evidence of pulmonary artery hypertension. There is a murmur, which is because of the PS, okay? And there is a sound, which is not a P2, but the A2. So again, I want you to write down the answers to this. These are all exam questions again. What is the pentology of Fallot? What is triology of Fallot? And what is a pink Fallot, right? What is pentology? What is triology? And what is a pink Fallot? Okay. So pentology is a Fallot plus one more lesion, most often ASD, sometimes a PDA. Okay. So you can have a Fallot's anatomy along with an ASD additionally, or a PDA. That's what you call as a pentology. A triology is PS plus RVH with ASD. Okay. So it's a PS with RVH is the main thing, right? When you have an ASD on the side, that's what you call as a triology. And a pink Fallot is what I told you as acyanotic Fallot, where the PS is mild. Remember, as long as you ensure pulmonary blood flow, cyanosis will be less. That's the most important thing to remember, right? If you have good pulmonary flow, cyanosis will be less. So when you have a mild PS, whatever VSD, whatever you want, you can have. If you have a mild PS, cyanosis is less, which is when you will get what we call as an acyanotic fallow or a pink fallow. Now, what is the treatment for Tetralogy of Fallot? I don't know if you watched this movie. It's an excellent movie, something the Lord made, which talks about how they discovered to increase the blood flow to the pulmonary circulation, how they started Blalock toxic shunt, etc. So this is a very, very interesting movie. If you haven't watched it, I would recommend that you watch it. It's a brilliant movie, right? So how do you improve the pulmonary flow? There are many ways. So this is what we call as a Blalock toxic shunt, where you are connecting to the everything has to go to pulmonary artery, right? So you're taking out from the carotids, the innominate carotids, and then you're connecting it to this is from the subclavian to the pulmonary, or you're connecting to the ascending aorta to the pulmonary, or from the pulmonary to the descending aorta, or you're again doing from the subclavian to the pulmonary. So all these are different ways of increasing. You're just connecting the systemic to pulmonary flow, right? The more pulmonary flow you ensure, the less is the cyanosis. So these are all palliative procedures which were developed before the complete correction for the tetralogy came in. These were the ways by which people with Tetralogy of Fallot survived. Okay, so these are the Blalock toxic shunts and the Watterson shunt and the Pod shunt that are sometimes asked for you. But the basic principle is this, that you ensure more pulmonary blood flow. Now, if you want to correct completely, then yes, you go and repair the pulmonary artery. Okay, widen it, put a patch there, close the the VST, and reposition the aorta. That is called complete correction of or repair of the Tetralogy of Fallot, which is curative. Of course, all these people will have to be on infected endocarditis prophylaxis for life, because after that also they will have problems. So this is how you treat the Tetralogy of Fallot, but otherwise there is no medical treatment for the Tetralogy of Fallot. It has to be surgical. Okay. Now I'll just focus a few minutes on some common problems in cyanotic congenital heart disease before I go on to Ebstein's and the others. Okay. Now, common problems are cyanosis, hypoxia. So when you give oxygen, there's no target. Okay, you just give oxygen for symptoms. So your patient with Tetralogy of Fallot complains of hypoxia, cyanosis, etc. How long do you give? You just give whenever oxygen is needed. Measure the saturation at rest, not at exertion, for you to understand the degree of pulmonary flow. Always measure it at rest. You have to prevent infections in patients with complex congenital heart diseases, not only Tetralogy of Fallot, the others. So you do give the vaccines, the pneumococcal and the H influenza vaccine. What are the indications for infective endocarditis in congenital heart disease? If you have an unrepaired cyanotic heart disease, then you would definitely have to give infective endocarditis prophylaxis for any procedure that you do. Repaired congenital heart disease with residual shunts or valvular regurgitation. Remember, even when you repair, you may have some valvular regurgitation, etc. At that time, you will have to, even after repair, many of these people, because you're putting a prosthetic patch or a prosthetic device, they may require infective endocarditis prophylaxis. Now, there's some lab pitfalls which are interesting to know, that you have an erythrocytosis, like in polycythemia. When you say you can get a pseudo hypoglycemia, because especially if your blood doesn't reach the lab very fast, then you can get a pseudo hypoglycemia, because the blood sugar value in that blood will be low. That is because the RBCs do a glycolysis and eat up the sugar, the red cells. Okay, the INR can be inappropriately high due to inappropriate citrate levels, especially in patients with erythrocytosis. There is a relative anemia. Now, that's important to remember when you're treating a patient with a Tetralogy of Fallot, that because you've got an increased hemoglobin production, cyanotic patients have an increased iron requirement. You need more RBC, you need more iron. So iron deficiency is common. But even in the presence of iron deficiency, these people will have a hemoglobin which looks normal. Okay, because the hemoglobin is still in the normal range. They're already polycythemic. So you get what is called a relative anemia. But these iron depleted RBCs, microspherocytes, have reduced oxygen capacity, carrying capacity, and increased rigidity and fragility. And on the whole, there's an increase in whole blood viscosity, which is giving rise to the hyperviscosity symptoms. So sometimes these patients can have, giddiness, headache, all the hyperviscosity symptoms that we're talking about, they can have. But remember, that anemia can be easily missed in patients with tetralogy of Fallot because they can be iron deficient even in the presence of a normal hemoglobin. The other complications are, like we said, if you have so much hyperviscosity, probably have to do a phlebotomy. If there is a hemoptysis in Eisenmenger's, treat like any other Eisenmenger's. No routine anticoagulation is needed in all these people. But if you get an AF, then you treat it as usual. This is not about tetralogy of Fallot. Tetralogy of Fallot doesn't have AF, but I'm generally talking about other congenital heart diseases. Okay. So with that, we come to the end of tetralogy of Fallot and a few points about how to manage a congenital heart disease. Now we go on to the second important congenital heart disease, which is Ebstein's anomaly. Now these are all small chapters, but I think a little understanding, and then you'll be able to answer questions asked about them. Now, what is a Ebstein's anomaly? Ebstein's anomaly is, for example, this is a normal heart, but you've got a very low placed tricuspid valve, right? Displaced tricuspid valve that allows for a TR. Okay, so what happens is the right atrium becomes very large, the right ventricle becomes very small, there is an incompetent tricuspid valve, there is a TR, and most of the time you get an ASD there. Okay, so this is called atrialization of the it's not arterialization, the atrialization of the ventricle. Okay, so the ventricles becomes like the atrium, right? Because the tricuspid valve comes so low, this is called atrialization of the ventricle and a low placed tricuspid valve. This is what is called as Ebstein's anomaly, and it is associated with a very small right ventricle, a very large right atrium, a tricuspid regurgitation, and usually associated with an atrial septal defect, because the blood will start flowing from this right atrium to the left atrium, and that is where the cyanosis comes in. So here you have got a hypoplastic right ventricle. Look at the right ventricle, it's so small. There is an increased RV overload because there's a tricuspid regurgitation. So all the blood goes back into the tricuspid and comes back to you from the next cycle. And then you got an ASD, and that ASD is opened up. And so most often you get cyanosis. Now, because of the low placed tricuspid valve and interference with the conducting system of the heart, it's often associated with an aberrant pathway, which is usually a WPW, and that is why there is a propensity to get arrhythmias. A lot of arrhythmias come in an Ebstein's anomaly, right? Okay. So what are the symptoms of an Ebstein's anomaly? Patients are cyanosed. Remember, you have a right to left shunt across the ASD. There is fatigue and dyspnea because you have a TR, you don't have enough blood going into the lungs, etc. There is palpitations because of arrhythmias, which are common, and they can present a sudden cardiac death. Paroxysmal SVT is very common, often associated with the WPW syndrome. Then there are features of right heart failure, such as edema, ascites, etc. So everything, there is a load on the right side, but there is a cyanosis because there is a communicating ASD. Now, what findings do you find on examination of an Ebstein's anomaly? You get cyanosis and clubbing. You get a large A wave and a V wave also, because there's a tricuspid regurgitation. There is a parasternal heave. There is a split S1, soft M1, but a louder, T1. There is an S2 split because of the RBBB, okay? Because most often there are blocks associated with it. So RBBB can be there. So there's an S2 wide split because of the RBBB. S3 and S4 are common. That is why you say multiple sounds. When you say an Ebstein's anomaly, how do you remember an Ebstein's anomaly? You remember that this patient has cyanosis and the patient has a wide splitting of the second sound, and there are multiple sounds. S1, S2, S3, S4 is also there, and a typical organic TR, organic tricuspid regurgitation, which is a pan-systolic murmur at the level of the tricuspid valve because of the very low placed tricuspid leaflets. So these are your findings of an Ebstein's anomaly. Now, what do you find on the X-ray? What you find on the X-ray is there's a cardiomegaly, because again, most of the blood is coming to the right side, also going to the left side. Right ventricular hypertrophy is known. Pulmonary oligemia, because again, most of the blood is going back. So there is a pulmonary oligemia. So that is what you will find here. There's pulmonary oligemia, right ventricular hypertrophy, and a cardiomegaly. The ECG will show broad P waves, prolonged PR interval. Again, like we told, the conducting system of the heart is interfered with. So you have a lot of blocks. You have a first degree block, you have an RBBB and a fragmented QRS, and you can have a WPW, and you can have tachyarrhythmias, all of these because you have interfered with the conducting system of the heart, giving rise to both blocks and tachyarrhythmias, which is what you're seeing on this ECG. So you got a prolonged PR interval, you got an RBBB, and you got a fragmented QRS, and there are tachyarrhythmias that can be present. WPW is a common association of Ebstein's anomaly. On an echo, what do you see? You can see beautifully the very low placed tricuspid valve here. So that's the right atrium, right ventricle, and you can see the very low placed tricuspid valve. That's a diagnostic feature of an Ebstein's anomaly, which gives rise to almost no ventricle at all. Ventricle is so small, atrium is so large, which is what you're making out here. You can also do an MRI or a spin echo of the Ebstein's anomaly, again showing you the presence of the very low placed tricuspid valve, which is what is shown by the arrow here. Okay, and the treatment is of course only symptomatic. So if there's an arrhythmia, you treat it. If there is a WPW, you treat with a drug or a radiofrequency ablation, treat the congestive cardiac failure, and then you can do a corrective surgery. Okay, so treatment is symptomatic medically or correction by surgery. So that's about Ebstein's anomaly. It's a small chapter, but once you understand it, it's very easy, and it's one of the important causes of an organic TR. Remember, an organic TR with a cyanosis and multiple sounds, okay, is probably an Ebstein's anomaly. Right. We go on to the next small chapter that we come across in cyanotic congenital heart disease, which is transposition of the great vessels. Now, what is transposition of the great vessels? You just switch the aorta and the pulmonary artery, then you get a transposed great vessel. So, for example, the aorta has come to the right side, the pulmonary artery has gone to the left side. So, it's called usually a dextrotransposition. And remember that if you have this and you have no communication, the patient will die, and without correction, there will be definitely death. So, just switching the arteries across the ventricles is what is called transposition of great vessels, and it's usually called a dextrotransposition. I will explain what is the levo later. So you can see the aorta transposed, you can see the pulmonary artery transposed. So it's a very bad thing to have. This circulation hence becomes in parallel, right? There is no, it's not that you come to the right side, go to pulmonary, then come to the left side. This is like two parallel circulations. Impossible to live. So you must have a shunt. You must have a shunt for a transposition patient to be alive. So what is that shunt? It can be at the level of the atrium, or it can be at the level of the ventricle, or it can be in the form of a PDA. So a transposition of great vessels usually is associated with an ASD or a VSD or a PDA. The commonest is an ASD. The rest of the people have either a VSD or a PDA. Otherwise, it's impossible to live, right? Now, what decides the course of a transposition? The ventricular efficacy. So you put the aorta on the right side, you put the pulmonary on the left side. Now, how is the ventricle going to survive? That decides. What is the status of the pulmonary bed? The pulmonary bed goes in for a severe arterial hypertension, then you're finished. The shunt efficacy, okay, you got an ASD, VSD or a PDA. How good is that shunt working out? Is it able to manage the cyanosis? That's what it is. And the tissue hypoxemia. So unless you have any of these things which are in your favor, a person with a transposition of great vessels cannot survive at all. Okay. So survival is only because of a shunt. Even with the shunt, survival is difficult. Okay. What are the findings? Presentation in children. Otherwise, unless intervened, they will never come as adults. There's a single again, I put the wrong thing. It's a single S2. Sorry for this error again. Ejection systolic murmur can be heard in the pulmonary area, and it becomes a differential diagnosis for a fallow. So how do you treat a transposition? Of course, like I told you, transposition coming to adults itself is difficult. They do not survive. Even if they have a shunt, it is difficult for them. The only thing, if they can survive because of the good efficiency of the pulmonary circuit, then they will come as adults. Otherwise, very, very rare to have a dextro transposition and be alive. Now, how do you manage a transposition? we can do either what is called an atrial shift switch or an arterial switch. So either you can interpose the atriums and get the good blood into the right side, the bad blood into the right side and the good blood into the left side again. That you can do. You can just switch the atria or you can switch the arteries. So that is the correction, surgical correction for a transposition of great vessels. Okay. So it's like an impossibility. Now, what you can see in adults is what we call as congenitally corrected transposition or an L-loop transposition. So you do not see this TGA that we are talking about, that is only in children. If you got a congenitally corrected transposition, what we call as a corrected transposition, that is the one which can be surviving in adults. What do we mean by this congenitally corrected transposition? Is atrioventricular discordance, but ventriculo-arterial discordance. So you can see here, this is the right atrium and this is the left ventricle and this is the pulmonary artery. Similarly, left atrium, right ventricle, but goes into the aorta. So you just switch the transposition, is congenitally corrected. So that is why this person is able to survive, because there is another transposition happening there, which is like a shunt and which corrected itself. So this kind of a person can survive till adulthood because you're correcting the RA to the LV, but going into the pulmonary artery. Similarly, you're correcting the LA to the RV, but you're correcting going to the aorta. So you're still having some amount of good blood going from the LA to the aorta and the bad blood going from the RA to the pulmonary artery. So you're still okay with it. So this is called congenitally corrected transposition, which is the only congenital heart disease cyanotic that you can see in survived in adulthood. This is called the L-loop transposition. Remember, all transpositions are because of wrong folding of the heart. Okay, remember, the atrium, ventricle, and the aorta are all one long tube, and they are folded upon each other. In the embryology of the heart, they are folded upon each other. So if you fold wrongly, you will get transpositions. This is a congenitally corrected transposition because the arteries are still switched. Okay, so this is possible. Now, what do you get in this? In a congenitally corrected transposition, these people may survive till adulthood. They may be presenting asymptomatically, or they can have a bradycardia because of the high degree AV block. Again, they can have a single S2 because of an anteriorly positioned aortic valve. They can have one of these murmurs because these can all be associated with them. Cyanosis is possible, heart failure, and tachyarrhythmias. So if at all you see an adult with a transposition, that person probably has a congenitally corrected transposition, that the arteries are switched and still carry out their functions, only the ventricles are wrongly placed. Okay, again, this is a differential for a single S2. The next chapter is a double outlet right ventricle. Now, what is a double outlet right ventricle? Simple, that the right ventricle is the one that is hosting both the aorta and the pulmonary artery. Both of them are sitting on top of the right ventricle and no artery is given to the left ventricle. Obviously, there's a large VST there, but everything is sitting on the right ventricle. Okay, this is usually associated with a VST or a pulmonary stenosis or a TGA. Okay, can be associated with one of these, and this is how it looks. And like I told you, the DORV with PS, okay, double outlet right ventricle with a pulmonary stenosis is the closest you get to a Fallot's. So if the important differential diagnosis for Fallot would be a double outlet right ventricle with a pulmonary stenosis, which is what we are talking about here, right? So what happens in a double outlet right ventricle? Of course, there is a cyanosis at birth because you got a double outlet for the right ventricle. There is a VSD, everything is getting shunted, and the clinical presentation, again, like in a Fallot, depends upon the PS. What is the pulmonary stenosis there? It's very close to the Fallot's anatomy in many ways, except that the aorta is not overriding. The aorta is sitting on the right ventricle. That's the only difference, okay? But otherwise, it's exactly like a Fallot's tetralogy. So we look at the causes of S2. You remember single S2, so many causes that we talk about. Either you say they are absent A2 or absent P2 or a single S2. Okay. So absent A2 is when you have an aortic stenosis or an aortic atresia, which we have not talked about here. Now, in that case, the aortic second sound is absent. So all you're hearing is the P2. Conditions where P2 is absent is truncus arteriosus, severe TOF, severe PS, and congenital heart disease associated with pulmonary atresia. In all these conditions, the P2 is absent, okay? That is why you get a single S2, right? Everywhere I made the mistake of writing S1. Please excuse me. I think it is S2 that you have to remember. And where you get a merging of the A2 and P2, that is in Eisenmenger VSD. So when you're asked in the exam also, what is the cause of a single second heart sound? Remember, you must not have A2, like in a very severe aortic stenosis, aortic atresia, there will be no A2. Or you must not have a P2, whether pulmonary stenosis is very severe, severe TOF, or truncus arteriosus, or some other condition which is associated again with PS or pulmonary atresia, or merging of both the sounds. Last class we discussed Eisenmenger's VSD. We said that in Eisenmenger's VSD, there is a single second heart sound because both the A2 and the P2 are coming together there to merge into one sound. So these are your causes of single S2. I think you will understand now that we have finished, because we have finished the other congenital heart diseases. Moving on to probably the last congenital heart disease, that is TAPVC, total anomalous pulmonary venous drainage. I did talk about it in the last class, but I mentioned it in passing. I thought I will mention it better here because this is also a cyanotic congenital heart disease which can come to you as a patient. Now, what happens in a total anomalous pulmonary venous drainage? All the pulmonary veins, instead of draining into the left atrium, are draining into the superior vena cava or on the right side. Okay, so all of them are going to that side, and there is an ASD there, right? That's how you are getting back some blood into the left side, because otherwise where will the left side get blood from? So all the pulmonary veins are going off on the right side, joining with the SVC or joining with the atrium, and then it manages to survive because there is an ASD here, and that pushes the blood into the left side. Obviously, cyanosis will be there. But the cyanosis in TAPVC is actually mild because overall, whatever blood you are getting this side is oxygenated blood. You're not getting deoxygenated blood. So it's like oxygenated to deoxygenated. So it's actually, even though there is a shunt and even though it's right to left, most of the time TAPVC presents with mild cyanosis, and that is how you tend to miss it in the examination. Now, the easiest way of remembering a TAPVC is that it is an ASD with cyanosis. When you think it is an ASD, okay, but there's no Eisenmenger, there's no Eisenmenger. It's an ASD, but you got a cyanosis. Then you think of a TAPVC. So the findings are the same. You get a wide fixed S2, okay, an ejection systolic murmur, a tricuspid MDM, and all features of ASD with a mild cyanosis is what we get in a TAPVC. So an ASD with cyanosis can be two things. It can be an ASD Eisenmenger's, or it can be an ASD, not an ASD, but a TAPVC. So the TAPVC is exactly all the findings of ASD with a little cyanosis. That is when you would think it's a total anomalous pulmonary venous drainage. What do you get on the X-ray of a TAPVC? It's a very classical X-ray because of the completely the pulmonary veins coming and draining into the SVC, etc. You get what is called a snowman appearance. This is a snowman appearance that you see here. This is what you get in the X-ray. This is how the snowman looks. So TAPVC chest X-ray is sometimes kept for you in the exam and asked, what is this? Now it looks like a mediastinal widening, but if it's a cardiac case, then it is a TAPVC. And you can do the echo and show that all the pulmonary veins are actually coming to the right side, draining into the SVC, or they are draining into the RA. The treatment for a TAPVC is only surgical correction. And the most important thing to remember about a TAPVC is that TAPVC is an exact replica of an ASD with a little cyanosis, right? Not gross, little cyanosis. I'm coming to the last chapter. I finished all the cyanotic congenital heart diseases. I thought one more disease that is important for you, which is acyanotic, but important for us to see in real life, is coarctation of aorta. So I'll spend the last 5 minutes on this. So what's a coarctation of aorta? We know that when there is a narrowing of the aorta, okay, that is when you call it as a coarctation of aorta. Now, remember that the aorta arises from these aortic arches, which are present last time when we did the PDA, I told you. And this is how just close to the PDA, you get a narrowing of the aorta, which you call as a coarctation of the aorta, right? Okay. Now, where is the coarctation? Usually it is post-subclavian. What do we mean by post-subclavian? You can see here beyond the subclavian artery, this is where you get the coarctation. So it's usually post-subclavian. Okay, that's why the upper limbs are not affected. Even the left upper limb is not affected because it's post-subclavian. The left-sided subclavian artery is taken off. Okay, so that's not affected, right? Beyond that, you get a narrowing. So obviously, the blood flow to the lower limbs will be less, the upper limbs will be more. That's what you get in a coarctation, right? It's often associated with Turner's syndrome. Okay, so when you get a patient with a coarctation of aorta, you have to look for the features of Turner's. You know about Turner's exo syndrome, web neck, etc. All those things you have to look for, right? So that's about the coarctation. What are the clinical findings of a coarctation of aorta? We all know that whenever we see upper limb hypertension, okay, there's a hypertension. Of course, we are going to measure the BP only in the upper limbs always. So the patient has hypertension, that's where you begin, right? Patient presents with headache, okay? That is because of increased blood going to the head. So coarctation prevents the blood from going to the lower limb, but upper limbs and the head are getting a lot of blood. So the patient can have headaches, okay? Now, whether both are only right side, that depends on pre or post subclavian. Whether this hypertension is on both upper limbs or it's only on one upper limb, that depends upon whether the coarctation is pre-subclavian or post-subclavian. I told you most of the time it is post-subclavian. That is why both upper limbs you get same high blood pressure. But if in case you have a pre-subclavian coarctation, then what happens? The upper limb BP in the right side is high, but the left side is normal or low, right? So if you get like that, then you make a diagnosis of pre-subclavian coarctation. Lower limb claudication, of course, you don't have blood going to the lower limb. So the patient comes to you with claudication, typical history of claudication, but you've got hypertension, right? Hypertension in the upper limbs, the low blood pressure in the lower limbs will be giving rise to claudication, right? So one of the causes of limb claudication, apart from your peripheral vascular disease, is a coarctation of aorta, which is what is you often asked for you even in the exam. So upper limb hypertension, lower limb pulses are feeble, BP is lower in the lower limbs. So this is one condition where you should take the blood pressure in the lower limbs also. So you get a hypertension in the upper limbs and you don't feel a pulse in the lower limbs, then definitely you have to record the lower limb blood pressure to make out that there is a coarctation. Brachiofemoral delay, yes, this is often told. Most times postgraduates they'll just tell like one reciting a rhyme, isn't it? There is no brachiofemoral delay. Now this is applicable in a coarctation because there is a delay between the upper limb pulse and the lower limb pulse. It's an important cause of secondary hypertension. So when you see a young person coming to with hypertension, okay, obviously you're thinking of either endocrine cause or renal cause or coarctation or an SLE, your usual classification of secondary hypertension that you all know, right? The big chunks are always renal and endocrine. Then you come to vascular. In the vascular, the coarctation of aorta is a very, very important cause. My cardiology professor always taught me this: touch the feet of every young hypertensive. When you get a young hypertensive patient, go and touch his feet, he says. That is because you must not miss a coarctation, right? So if you have a young hypertension patient, always see for the dorsalis pedis. The dorsalis pedis is not there, then probably you have to measure the lower limb BP and think of a coarctation, okay? So it's an important cause of secondary hypertension. What are the symptoms and signs? Of course, you get, there's like symptoms I've already discussed. It's a coarctation. So you got a hypertension. So you got a left ventricular hypertrophy, heaving apex, ejection systolic murmur in the pulmonary aortic area and a loud A2. These are all part of the coarctation. Palpable collaterals can be seen in the interscapular area, isn't it? So because the coarctation is there, there's an attempt by the body to develop the intercostal collaterals and somehow get blood to the lower limbs, right? So that is what you're seeing in the interscapular area. You strip the patient and look for collaterals. There is a murmur at the interscapular area, which is what is called as Sussman sign. There's systolic murmur there that you can make out, and often associated with AS and AR, because bicuspid aortic valve is an important association of a coarctation of aorta. Associated intracranial aneurysms, so that is why they can have berry aneurysms and they can have subarachnoid bleeds. Now that's how the collaterals look in coarctation of aorta. Beyond the coarctation, these are the intercostal arteries which are trying to hook up with any artery they get, okay? From the internal mammary artery, the vertebral artery, any artery they get, they're trying to get blood from them and push it to the lower limbs. And that is how these intercostal arteries which are running there, they are present in the interscapular area. And these are the ones that you can either palpate or auscultate in a patient with coarctation of aorta. What do you see on the chest radiograph of a patient with coarctation of aorta? You can see here the coarctation, the subclavian artery, which is seen here, which is ectatic. Okay, there is a rib notching that is seen here. And this is what we call as the three sign, where there is like a waist of the aorta. The aorta is narrowed there and then it comes back to normal. That is called the three sign on a lateral X-ray. And this is the rib notching and this is the ectatic subclavian artery. Now that is an X-ray which shows you the rib notching better because the intercostal arteries are in the lower part of the ribs, remember, and they will pulsate and on the bone, and that's why you give rise to rib notching. You can see here, it's usually present from the third, fourth intercostal arteries, which is what is shown for you in this X-ray. ECG, of course, shows LVH, which goes without saying, and imaging shows the CT scan can show the presence of the coarc there. Okay, you can see the coarctation there, which can be delineated and then can be taken up later. Now, what is the treatment for a coarctation? The treatment for a coarctation is always surgery. You can either do a stenting or a surgical connection. So it's very very important to make a diagnosis, because otherwise your young hypertensive will be walking around with no diagnosis, being given all kinds of antihypertensives, and ultimately he may go into renal failure and all target organ damage. Whereas this is a correctable condition in a person who can be corrected. You can give them a reasonably normal life. That is why coarctation is very important to diagnose, especially in the young people with hypertension. So with that, I have finished this class on congenital cyanotic heart disease and one extra, that is coarctation. Thank you all for a patient hearing.
Yes, thank you, ma'am. There are two questions.
Yes.
One is, can we re-explain the shunt in the top?
Re-explain what? Re-explain what?
Shunt in top tetralogy.
Oh, 1 minute, 1 minute.
Yeah, sure.
Yes. We said that the shunt in the top is actually from the RV to the aorta. Okay, the deoxygenated blood is going from the RV to the aorta because the aorta is overriding. It's an overriding aorta. So the aorta is sitting on the right ventricle. So what do you mean by shunt? You are talking about a right to left shunt. Where is the right to left shunt happening? It is happening at the level of the RV to the aorta. Here it is a bidirectional shunt. This is a bidirectional shunt, isn't it? It's a large VSD, non-restrictive. Nobody knows which way the blood will go. It can come from left side to right side or right side to left side. The only place where it goes from the right side to the left side is from the right ventricle to the aorta. That's what I meant by saying that the shunt is actually the right to left shunt in a TOF is from the right ventricle to the aorta. Is that clear?
Yes, ma'am. And one more, even I like this question, that young person with hypertension, specifically in the upper limb.
Yeah.
How do we differentiate from Takayasu? And I think we also have the similar question in our DM also. This is favorite case for us. Yeah.
Yeah. So Takayasu can be of 5 types and all. No, Sanket, you should be able to tell better than me.
Yeah.
Including pulmonary artery hypertension, which is the last one.
Yeah. The best thing to differentiate is asking the history of constitutional symptoms, fever, weight loss, fatigue,
Yes.
they are very common in tech,
Yeah.
which will not happen in coarctation much.
Right. Right. And
So
it's actually
that's the
reverse
one point we try
coarctation.
to.
No, it's a reverse
Yes,
coarctation. You
yes.
can have
Right.
less in the upper limb,
Mm.
more in the lower limb. It's a reverse coarctation.
Yes.
And I really like what you said about the fever. I actually had a patient who came with a PUO. Okay.
Yeah.
One lady who was 35 years old, walking around so many hospitals with a PUO, undiagnosed. And actually, we also didn't diagnose. We only realized that the ESR is high. So we
Okay.
went and did one CT chest, thinking that the
Okay.
ESR is high. We may find some mediastinal adenopathy, something else that we have missed. And we were surprised to
Yeah.
find that there was a tachyosis. Okay.
Correct.
And then actually, it's a mistake on our part. We found actually the upper limb pulses were not felt in a Takayasu. I mean, she did not
Yes.
have. We completely missed it.
Correct.
That is because everybody took the right side upper limb. The left side was
Yes. Yes.
absent. Okay. So
Yeah.
we always say, no, right
The-
upper limb, supine posture. I
Yeah.
don't know why we're
Yes.
so much
Yes.
in favor of the right one, but I think we should look
Yeah.
at both pulses, right?
Both.
So the
Both. Yeah.
Takayasu is actually a reverse coarctation, and it can have at multiple levels. Okay. Like we said, there are 5 types of Takayasu.
Yes.
Okay. And you can have bruise all over. I have seen Takayasus having iliac artery bruise. Okay. And all kinds of bruise at multiple sites. Okay. It's not one site. And constitutional symptoms are a very, very important part, and a high ESR. That's how I would differentiate.
Yeah. Yes. So Takayasu, I think everyone like my first case in postgraduate was hypotension. I gave 3 inotropes. So I'm honest to commit that. And then next day we checked the low. The only clue there I got was that this lady is on 3 inotrop and pouring urine like crazy. So that does not happen. BP is not recordable, but urine is coming.
Right.
So sometimes we learn by this.
Right. Yeah.
Yes. Yes. Okay, man. Okay, man. Thank you.
Thank you. Thank you
Yes.
very much. Bye-bye.